2, 1. All right. Hello, everybody, and welcome to the fourth talk in our speaker series for the 2021-2022 school year. So today I'm very pleased to announce or to introduce Dr. Elaine Hyshka, who is an assistant professor and Canada Research Chair in Health Systems Innovation here at the University of Alberta in the School of Public Health. All right, so without further ado, I guess her talk is titled "First, Do No Harm: Improving Hospital Experiences for People Who Use Illegal Drugs." Yeah, without any further ado, I will turn it over to Dr. Hyshka.
Great, thank you so much. It's a nice opportunity to be here, and I think it's very exciting to be able to speak to colleagues at the university and beyond about my work. So I just want to start by acknowledging that obviously as faculty at the University of Alberta, my work and research is situated on Treaty 6 territory, which is a traditional gathering place for diverse Indigenous people, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, and Anishinaabe people, as well as Inuit people. So when I was first invited to join your webinar, I was a little surprised because although I do have a bit of a background in sociology with a bachelor's actually from the U of A and a master's, my current work is very much applied and focused on evaluating and improving health systems and services for people who use substances. But I do think that there are some interesting parallels between the work that I've been doing since I first started my faculty position here in 2016 and work that some colleagues at the Center for Criminological Research are doing. And so I think it would be nice to see more formal collaboration between our groups. And obviously, I think we work with very similar and overlapping populations of people. So today I decided to focus my presentation on an area of shared interest, and that is the implementation of harm reduction programs. And we were just actually talking before the lecture started about how the Center for Criminological Research is doing some, or has some research related to implementing harm reduction in institutional settings like correctional facilities. And I do think that there are some learnings that we've developed on our team when we look at how to implement harm reduction in hospitals that may be illustrative also for that work. So I'll start with a bit of background, and then I'll go over our research program and just give you a sense of kind of the structure in which we're working. And then I'll just review a few of the studies we've had in the last few years focused on this topic with some conclusions and future directions. So it may be surprising to people that work outside of health, but hospitalization is a critical but often very overlooked opportunity to provide effective substance use care. And so historically, in both the United States and Canada, addiction medicine, substance use services have really not been integrated into acute care facilities. And in both the United States and Canada, substance use is accounting for a significant and increasing number of emergency department visits and admissions, as well as substantial healthcare costs. So it is kind of curious that traditionally acute care hospitals and programs are not really dealing with substance use, which is kind of viewed as more of like a chronic condition, not an acute medical need. But obviously that model's not working because it's really driving a lot of health system utilization. And I think many people, when they come to hospital, are potentially open-minded and willing to discuss their substance use and potentially make some changes around it if it's causing them problems. And so there is increasingly interest in improving care for patients who use illegal drugs and patients who use legal drugs in these settings. And it's really important to improve this care because we know that people who use drugs and have very poor hospital outcomes. So this includes epidemiological research that shows that people who use drugs are more likely to be discharged from hospital prematurely, so before they complete their medical treatment, and they're more likely to experience an unplanned hospital readmission. So people who leave hospital prematurely are actually 12 times more likely to be readmitted with a related diagnosis within 2 weeks, and twice as likely to die compared to those who complete their medical treatment. People who use opioids are particularly at risk or vulnerable because period of abstinence associated with a short-term hospitalization can lead to a reduction in tolerance, and that exacerbates the risk for drug poisoning or overdose when people are discharged and return to substance use. So consistently poor acute care outcomes for people who use illegal drugs has prompted urgent calls to improve hospital care, and we're certainly seeing across the United States and Canada more clinical implementation or clinical interventions being implemented, and a lot more scholarship looking at what is needed to improve care in these settings and how is it working. In particular, there's a growing body of research that evaluates various addiction medicine consultation teams or models. And these are increasingly being recognized as one important strategy for improving hospital experiences for people who use drugs. But what has received less attention in this body of work is really the potential role for harm reduction approaches within the provision of addiction medicine and other hospital care for patients who use drugs. So why is not attending to harm reduction approaches within acute care a problem? Well, we know from a lot of qualitative and quantitative research that hospitals can be actually a very high risk environment for people who use drugs. So we also know that most people who use drugs are not ready or willing to access treatment. And even when people are willing to access treatment in the hospital, it's not uncommon to see continued use early on in treatment as people are stabilizing. And so it's really not realistic to expect that all people who use substances will just stop using or abstain from use while they're hospitalized. And we do have data from Canada in Vancouver that shows that just under half of people who inject drugs, about 44%, report continuing to inject drugs while they're in the hospital. And for those that continue to use drugs, the hospitals become very high risk, and actually more of a high risk environment than if they were in the community. So Ryan McNeil and colleagues have documented how, the mechanisms that produce this risk environment for people who use drugs in hospital. And basically it's a constellation of unwritten or explicit abstinence-only expectations, which can lead to people using alone in washrooms or other unsafe settings. Inadequate pain and withdrawal management, which increases the need for people to supplement with illegal drugs. Stigma and discrimination from hospital staff, and negative encounters with security, as well as a lack of access to sterile injection supplies. And so all these factors are increasing risk for hospitalized people who use drugs. And many of the strategies that people would normally have to stay safe while they're using substances or try to stay safer are not available in the hospital, even if they are widely available in the community. So I think most people are probably familiar with the concept of harm reduction, but just in case, I thought I'd offer a brief definition. When we talk about harm reduction, we really are thinking about it as both a philosophy of care, so how you approach a patient and the ethical principles that guide your care, but also a pragmatic set of strategies. So that's things like naloxone or sterile drug supply distribution, supervised consumption services, so those kind of intervention pieces. And the point of harm reduction is to help people who use drugs be as safe and healthy as possible, and have more autonomy over their own lives, and also to take protective and proactive measures for themselves and their families and communities. And it's really important to know that there's actually decades of evidence from international settings that demonstrate harm reduction is effective for modifying risk environments and reducing risk of overdose or drug poisoning, risk of HIV, Hep C, and other drug-related morbidity and mortality. And it's also been shown to be effective at encouraging people who use drugs to engage with health and social services. So harm reduction approach definitely has potential to significantly improve acute care hospital experiences and outcomes. But almost no peer-reviewed research has documented implementation of harm reduction in acute care settings. So the Royal Oaks Hospital in Edmonton is one facility that's been attempting to address this gap and to bring harm reduction philosophy and practice to the acute care bedside. So for those that may be less familiar with the hospital, It has around 824 beds, and that's a bit of a moving target, especially during the pandemic and the need to kind of expand and contract and shift around resources. But it is one of the largest tertiary care centers in Western Canada, and it's one of the busiest emergency departments in Western Canada as well. And the hospital is located in central Edmonton, which for people that may be international or outside of Canada, is a city of almost 1 million people, and in a health services catchment that is socioeconomically marginalized with high population prevalence of unstable housing, substance use, and mental health disorders. So the area consistently has the highest rate of drug poisoning deaths in the city, exponentially greater than really any other part of the city. And the Royal Oaks Hospital actually sees the most substance use related presentations of any hospital in the province. So in an effort to improve patient care and outcomes for patients with substance use disorders and people who are using drugs, the hospital partnered with the Royal Alexandra Hospital Foundation and the University of Alberta to launch the Inner City Health and Wellness Program in 2014. And so the program includes 3 components, including clinical care, research, and education. So I'm the scientific director of the Inner City Health and Wellness Program, and I lead its research arm alongside Dr. Janetta Salvalaggio, who is associate professor in family medicine here at U of A as well. And our team is very action oriented, and we use a wide array of research methods to evaluate health systems innovations that promote health equity for people who use drugs and for other structurally vulnerable populations. Our team's embedded typically not during the pandemic, but normally we have an office on site at the hospital, and we work closely with the community advisory group of people with lived experience of substance use, unstable housing, and poverty. And we also facilitate regular collaboration between the hospital's senior leaders and members of this community advisory to facilitate the co-design of new clinical programs and services. A lot of our research has been focused on understanding and evaluating various different components of the clinical arm of the Inner City Health and Wellness Program, which is the Addiction Recovery and Community Health team. And that team is led by Dr. Catherine Dong. The ARCH team provides a multidisciplinary inpatient addiction medicine consultation service, as well as an outpatient transitional clinic. And both the service and the clinic are staffed with physicians, nurse practitioners, social workers, addictions counselors, peer support workers, and a pharmacist. And they provide the full range of evidence-based strategies for supporting people who use substances. In 2019, sorry, these are a little dated, I don't have updated stats because of the pandemic, but in 2019, ARCH completed over 2,200 consults with 1,630 unique patients, and that volume has only grown substantially with the onset of the pandemic. So the ARCH team's clinical care model was developed based on both scientific evidence and extensive consultation with people who use drugs, healthcare providers, and hospital and community leaders. Harm reduction services have been available in Edmonton since the 1980s. And actually, we were the first jurisdiction in Canada to implement naloxone kits. And so it's not surprising, given this strong tradition, that very early on, there was very vocal support for integrating harm reduction within ARCH's model of care across stakeholders. So the team started with a focus on practicing harm reduction philosophy of care and also integrated peer support workers with lived experience of substance use, naloxone kit training, and bedside distribution of harm reduction supplies. Eventually, the program has grown and now includes additional harm reduction strategies such as managed alcohol, as well as the first ever supervised consumption service for hospital inpatients. So because historically almost all harm reduction has been delivered outside of hospitals and even really outside of mainstream healthcare, from the outset, we determined it was very critical to study how evidence on harm reduction could be adapted into practices and interventions within acute care. So our research program adopts a learning health system approach, and we aim to produce new research on the health and social needs of people who use drugs in acute care, support translation of this research and evidence on harm reduction and substance use into new practices and policies in acute care settings, and then evaluate the implementation of these new initiatives, which enables their further refinement and also helps generate new knowledge that contributes to the spread of these interventions to other acute care settings in Canada and internationally. So once the ARCH team was operational, one of our first research projects included a process evaluation to better understand how the team was implemented and to identify barriers and facilitators to team success and areas for quality improvement. So the next few slides are based on a manuscript we published in Drug and Alcohol Dependence back in, I think, 2019. Yeah. And this was based on qualitative interviews and a focused ethnography done with ARCH patients between 2015 and 2016. So overall, the study's findings supported ARCH's model of care from a patient perspective, concluding that the range of services it offered and the way those services were delivered improved the hospital experience for most patients, though we did identify some challenges. So here I will just speak to the specific findings in this manuscript that address harm reduction. So patients told us, or participants told us, that the factors, that there was several factors that kind of made the ARCH experience or the care experience delivered by ARCH different from traditional hospital care. And these factors were really consistent with the harm reduction philosophy. So specifically, they reported that the team staff were non-judgmental, that they offered care in a compassionate way, and that they emphasized their patient autonomy and shared decision-making, which is honestly quite rare in kind of like a medical model, particularly like a top-down, more acute care hospital model. And that the team worked to build trust with each new clinical encounter and effectively manage pain and withdrawal, enabling people to feel more comfortable and more able to stay and complete their hospital care. Participants felt that their hospital experiences were overall improved, and they also highlighted how important the effective pain and withdrawal management was. And they also said that it was novel to have access to such a range of specialists and disciplines to follow up or to provide follow-up care and planning for post-discharge. But implementing a harm reduction-oriented addiction medicine consultation team within an institutional culture that historically has been very negative towards substance use also does come with challenges. And in this project, we really did identify a couple key ones. In particular, participants described that there was a very clear incongruence between how they were treated by members of the team and how some hospital staff on the units were continuing to treat them. So in some instances, patients reported being stigmatized or discriminated against on the unit, or they felt or attributed that staff actions to the fact that they were people who use substances. And this finding clearly emphasized the need for more work to shift hospital culture, including the development and implementation of formal policies and procedures that can detect, address, and sanction stigmatizing behavior of some staff. And it was a minority, at least from the perspective of the patients, to address it essentially and ensure that it doesn't happen. Another challenge was related to the ambiguous status of in-hospital substance use. So consistent with international best practice for HIV prevention, the ARCH team distributes sterile syringes and other harm reduction supplies to patients who report that they are currently injecting drugs. And obviously these supplies are optional, but they're offered to any patient that has a current history of injection use or now smoking as well. I just want to flag that if you're interested in learning more about this component of the ARCH team, we have another paper published in Drug and Alcohol Review that did look at patient uptake of this intervention. But although the hospital policy states that patients should not be excluded from care due to ongoing drug use, because, especially if you're thinking about patients that have substance use disorders, like ongoing drug use is a symptom of their health condition. But because drug use remains illegal, in-hospital drug use is still not actually permitted. So there is kind of like a gray status, or there was a bit of an ambiguity. So as a result, some patients told us that participants told us that they left campus to use substances, which is not ideal when people are hospitalized. And others tried to conceal their use in their hospital room or other areas of the hospital. And this led to a heightened drug poisoning risk potentially in both scenarios. When patients chose to use on campus, hospital staff, including the addiction medicine team, would either have to turn a blind eye to evidence of patient drug use in order to facilitate hospital treatment completion, or they would have to formally and informally sanction it. A few participants in our study reported that this ambiguity led to negative experiences. And in one instance, a participant was discharged after a unit nurse caught him injecting in his bathroom. So to ultimately resolve this tension around in-hospital substance use, the hospital decided to implement a supervised consumption service for registered patients where drug use could be formally sanctioned and patients would not have to fear discharge or arrest for drug use. And I think this was also at a time when we really did see the growing contamination of the illegal street drug market with fentanyl and other analogs that were leading to extreme poisoning risk. And so the hospital, like other hospitals across Canada, was also grappling with unattended overdoses or drug poisonings happening on their campus, either from patients or from people who were visiting the hospital. So there was a real impetus to address that problem and to try to make the hospital environment safer for everyone. So a supervised consumption service is a place that provides a sterile and monitored environment for people to consume pre-obtained illegal drugs and receive emergency overdose care, as well as other health and social supports. And internationally, there's over 120 formally permitted or sanctioned facilities that operate. Evidence has consistently demonstrated the benefit of these services for reducing the risk of death and connecting people to health and social care. In Canada, supervised consumption services are decriminalized spaces where staff and participants will not be charged with drug possession or trafficking as long as they adhere to the site policies when they're there. There's currently 37 federally approved SCS in Canada and several more provincially authorized services, and they are considered standard of care for patients with opioid use disorder. However, they have to date, I shouldn't say today, traditionally they've been exclusively implemented in community settings only. So this changed when the Royal Oaks Hospital opened their inpatient SCS in April of 2018. Later that year, a second hospital based in Vancouver also opened a supervised consumption service, but that one still primarily serves the general public with just a subset of people accessing care there as registered patients. And a third hospital was authorized last year to operate a supervised consumption service in Toronto. To our knowledge, the Royal Oaks was the first supervised consumption service internationally dedicated specifically to hospital patients. And so in designing the service model, we drew on qualitative data collection with hospital staff and patients and consultation with our team's community advisory group. The facility has 4 consumption spaces and a post-consumption monitoring area where people are encouraged to spend time before leaving. The service is accessible to registered inpatients as well as any patient that's already been triaged in the emergency department. Patients can self-present to the service or they can be referred by a hospital staff member. And all those that access the service are offered a connection to the addiction medicine consultation team. Patients sign an informed consent and patient agreement, and the unit receives a standard report when a patient attends the service. So this is obviously very novel to implement this kind of service in a hospital. And so the first phase of our implementation research really has focused on understanding which patients access the service and why some may not go, and identifying how the service is working from a patient perspective. So we're just currently completing a process evaluation of the service with 2 main objectives. The first is to analyze demographic and clinical differences between patients who do and do not go to the service. And we're doing this by looking at linked patient database. So the SCS has its own database that tracks patient visits, and we're linking that to hospital records and analyzing those data using multivariate analysis. And this is based, so we've assembled a retrospective cohorts here of 1,367 hospital visits from 817 unique patients. And then the second objective was to examine both patient and staff perspectives. And we're using focused ethnography for that. And we've completed 28 interviews with SCS eligible patients and 20 interviews with staff. So to measure the utilization, as I mentioned, we did a cohort study. We utilized generalized estimating equations with logit-link to analyze a variety of patient and hospital visit characteristics that are associated with SCS use. So during the 2-year study period, the SCS saw over 5,500 visits from 230 unique patients, and 36 overdoses were reversed. The majority of substances being consumed at the site are opioids, with a smaller amount of people reporting that they're using stimulants. And it's important to note that the site currently accommodates oral, intranasal, and injection drug use. So of the 1,367 SCS visits analyzed, or sorry, of SCS eligible patients, essentially patients visited the SCS in 292 of those hospitals visits. But we've noted that if a patient was returning to hospital or they had a longer length of stay, they were more likely to attend the SCS. And our multivariate analysis found that eligible patients, so that's people that reported injection drug use in the past 6 months, were more likely to access the SCS during their hospital visit if they reported having a recent overdose, if they reported injecting opioids at intake, if they were receiving specialist pain and withdrawal management, and if they were being titrated on opioid agonist medication while in hospital, or if they were being maintained on opioid agonist treatment after coming to hospital. So amongst the 292 hospital visits where a patient attended the service, 45% included OAT initiation and 32% included maintenance of OAT, that's opioid agonist treatment. Oops. So like, what are the implications of this quantitative set of data or analysis? So basically, patients at a higher risk of overdose are more likely to use the SCS, and that's consistent with research that's also been conducted in the community around supervised clinical services. Uptake increases with length of stay and repeated visits, and that could suggest that patients take time to learn about the SCS and trust it, or that patients are less able to abstain from substance use the longer or more frequently they end up hospitalized. Patients who are receiving withdrawal or pain management may be more willing to discuss the nature of their opioid use with clinical care teams, rather than just providing it for history. And so they may be more comfortable accessing the service because they've already disclosed details of their substance use. Or they may be topping up or diverting and injecting medications to achieve better symptom relief as they're being stabilized. Patients on opioid agonist treatment are more likely to use the SCS, and that is an opposite finding to the research we've seen in the community. Which normally, like in the community, people who are on methadone are actually less likely to use an SCS. But it's really not uncommon in the early days of treatment to see people continuing to use illegal drugs while they're titrating on their medications. And it's possible too that pre-hospital OAT prescriptions may not have been sufficient to meet their needs. So overall, OAT could also be a predictor for a more severe opioid use disorder. And certainly we're hearing more and more anecdotally with the changes in the illegal drug market that increasingly buprenorphine, methadone, like the traditional oral medications used to treat opioid use disorder are less effective for people, or if people are feeling that they're not necessarily meeting their needs, just because of the toxicity and the high potency of what's available on the street and what people are developing dependencies on. Further research is really needed, though, to understand these observations and address barriers to uptake and assess the impacts of the SCS on patients' hospital outcomes. Fortunately, though, we have been doing some qualitative work that does kind of help us to better understand the context of uptake into the service. And so here I'm just going to present a few findings from qualitative work that we just published not that long ago in the International Journal of Drug Policy. And we are looking specifically in this study at the motivations for attending or not attending the service. And so this study is based on 28 interviews with SCS eligible patients, 8 of whom chose not to attend the service during the study. And we applied Tim Rhodes' risk environment framework to understand the factors that motivate patients' decisions to attend or not attend the SCS. So participants who did go to the SCS were motivated to do so out of a desire to protect their own health and the health of other people around them. They reported going to the SCS because it helped to reduce their risk of dying from a drug poisoning. And many that we talked to did say that they had previously had overdoses in the hospital. And they also did so to ensure access to sterile supplies to reduce the risk of HIV and hepatitis C, as well as to provide an opportunity or to get an opportunity to dispose of their used needles safely. Participants who attended the SCS also appreciated not having to worry about being interrupted by the police or by security, like hospital security, some of whom are peace officers, or being judged or sanctioned by hospital staff. In contrast, though, the participants who delayed going to the SCS or who maybe did not go at all reported that they were unable to overcome kind of similar concerns. Some really said that they did not trust the service and feared that the supervised acceptance site was a trap set up by the police or by security to detect and arrest people in possession of drugs at the hospital. Some also felt unsafe going to the SCS because they worried that the news that they had been there would travel back to their unit and that they would then be subsequently treated differently by the unit staff. And then there's also some policy barriers to accessing the service. As I mentioned earlier, the service actually doesn't accommodate smoking or inhalation. And we are seeing definitely amongst patients going to the hospital for substance use, an increase in smoking and a decrease in injecting over the last few years. Also, it's important to note that drug use is really inherently a social activity. And many people also split drugs or buy drugs together and are taught to use together for safety. So using alone is a big risk factor for overdose death. So because of this, some participants chose not to attend the SCS because they were not allowed to bring a visitor or a partner with them. And they worried about the potential for a drug poisoning if the person that was not eligible to attend the SCS or to go in was forced to use alone outside. So overall, this study really showed that patients are motivated to attend the service, but they really need to feel safe doing so. And that there is a need to rebuild trust with people who have had prior negative experiences with staff or who have had current ones, and to continue efforts to counter stigma in the hospital. Criminalization and fear of police and security really animates a lot of decision-making made by patients in the hospital. And it remains a substantial barrier for some people in terms of being unwilling to go to such a service. So you've heard a lot from patients today, and I just want to briefly flag that we are doing research with staff as well. We're still kind of doing the analysis, so these are really preliminary findings of some of our qualitative data collected with staff. But I'll just go over a few things based off 20 interviews that actually do the data are showing that in some ways they corroborate some of the patient findings and suggest that when patients are able to access the SCS, it can be a useful clinical tool. So staff corroborate the patient perspective that some people will not go because they worry about retaliation from their home unit, and they told us that in some instances they've witnessed changes to patients' medication regimes or the withholding of PRN medications like opioids or for pain because the patient had attended the SCS recently. There's also policy barriers that the staff have witnessed, and they said they've also observed people not attending the service when they had guests, for example, or because they were smoking drugs. Staff report also having that the SCS it does help to facilitate institutional culture change, which is interesting. They say that it helps to normalize the hospital as an appropriate site to address patient substance use, and it gives staff a solution other than turning a blind eye or sanctioning patients who use drugs on the units. Staff also feel that when they know substance use is occurring, they can better tailor their care to meet patient needs. And this is particularly true when they're titrating people on medications, for example. So if you're starting someone on buprenorphine or methadone, knowing that they're continuing to top up by going to the supervised type of service actually can make it easier to increase the prescription sooner and to try to meet people's needs so that they don't have to use illegal substances if they're trying to achieve abstinence. And then staff also reported that they felt that the service did make the environment safer for them, and that they noticed less discarded needles, or they felt less unsafe potentially in that they may encounter discarded needles or other threats to their safety related to drug use. So in terms of future directions, we're going to finalize our analysis of the staff data and get some publications up this year, hopefully. We also will be applying for funding to evaluate the patient outcomes from looking at like medical records and health administrative data. So looking at whether the supervised consumption services service does actually help people to stay in hospital longer, and if they have better health care outcomes if they're accessing it. We also have a paper we're working on patient-reported impacts of the service. So another qualitative paper. And the implications kind of this body of work to date is that it really is a long process to adapt harm reduction interventions to the acute care setting and identify strategies to refine them that lower barriers for patients. Like, hospitals really are essentially a very high barrier environment for people who use substances, and they're really not necessarily oriented around a philosophy of care that involves harm reduction. So it does take a lot of time to shift culture and adapt it to the realities of people who use substances. But it's important to do, because if we don't do that, we really won't achieve health equity or parity in healthcare for this population. It's also important, to note that hospital culture takes a long time to shift, in part because there are thousands of employees that work at a given hospital. And so, there are different stages of training, different stages of their career, and opportunities for professional development, even in this context, are very abundant, but it just can be difficult to support people to be able to engage in those opportunities effectively. And then the one thing that really is a thread that runs through a lot of our research in the hospital, not just these studies, is how the risk of criminalization substantially shapes the way that people engage with formal healthcare. And it really does suggest that decriminalization and drug law reform could facilitate better healthcare encounters, making patients less reluctant to identify someone who uses illegal drugs, and also clinicians less likely to surveil patients or to treat them poorly. So I'll just wrap up by noting that although I focus today on harm reduction, like from an addiction medicine team perspective, or the supervised detention service, our team has conducted a lot of other projects looking at things like in-hospital syringe distribution, naloxone kit provision, managed alcohol, as well as facilitating access to opioid agonist treatment. And so more of those projects and the publications from those projects and reports can be found on our website, which is itchwic.ca. And so I will leave it there, and I think we have some time for discussion and questions.
Okay, just while we give Dr. Hyshka a second to catch her breath after that presentation. Yeah, we'll give you a second to have a drink and catch your breath for a second. I just want to quickly announce our next talk, which will be February 25th. It should be at the same time. We're still just confirming the details because we have another guest from the UK. So sometimes the time difference makes things a little bit tricky. So just keep an eye on your email and on our social media. Twitter, we're at CCRU of A, and you can find us on Instagram as well. And I will be sending out a department email as well in the week before. But we have Elke von Helmont of University of Kent. And she'll be doing something, she hasn't given us a title yet, but related to her research on kind of ethnography of radicalized street gangs and, her work on social media and gangs. So, once we get a title, we'll announce it and we'll put it up on social media. So, there's my phone. My phone rang for some reason. Okay, yeah, sorry about that. Yeah, so keep an eye on that. Elke obviously is a very interesting and important guest. So we're looking forward to that a lot. And with that, I guess we've got our first question on the chat here, and I'll just read it out from Jeff Crepeau. So he says, "Hi, Elaine," or they say, sorry, I don't know. gender. Hi, Elaine. Thanks for this presentation. I wondered if you might comment on the Alberta government's ID policy coming into effect on Monday and how clients at the SCS and others might be affected.
Sure, I can. So in the context of the hospital, it doesn't have significant implications because registered patients, you have to be a registered patient to attend the SCS. And so already the patient's personal health number has been disclosed to the hospital and the patient is identified in that setting. So it won't really change anything practice-wise that way. In the community is a different story. So I want to disclose I'm actually an expert witness in that litigation. And so I did submit evidence basically based on research that we conducted in Alberta, which shows that a majority of people in every city except for Fort McMurray, which was a slim minority of people, said that if they have to show identification, they would not be willing to attend a supervised acceptance service. So PHN is a personal health number, is a form of identification. It can be linked very easily to your name, your address, your gender, your sex, a host of information about you. So I do worry, and I did submit this as part of my evidence, that there will be people that will not attend the service because it's no longer anonymous for them. And I think it is legitimate to have concerns about those records being linked to other health systems databases and for clinical encounters and other settings to result in different treatment because the SCS records are now part of the health record. So that was heard. There was a court, actually an appeal hearing yesterday about the injunction decision. And so that court will be delivering its ruling within the next few weeks, I believe. So it's still TBD, but irrespective of the decision on the injunction, there will be a further trial, is my understanding.
Okay, wonderful. So we've got another question here, and just obviously feel free to turn on your cameras and ask your questions. I don't have to read them all out. Always interactions are more fun when it's not just me reading things. All right, so L'Oreal says, thank you for such an important and timely talk, Dr. Hyshka. I'm wondering, do you foresee any potential issues or barriers with implementing harm reduction within the institutionalized setting of a hospital? And I ask because institutionalized forms of harm reduction have been critiqued for prioritizing medicalized knowledge over experiential knowledge of people who use drugs and service providers. Institutionalized forms of harm reduction can also be heavily bureaucratized, which may act as a barrier to use. Can you speak more about how this model prevents such scenarios from happening in practice, and what, if anything, participants had to say about this? So there's a lot of questions there.
No, it's a good point though. And certainly there's lots of literature and scholarship that compares sort of like a traditional medical model with harm reduction philosophy, and they are incongruent in many ways. And I think the reality is that harm reduction is, a philosophy and a practice and a kind of worldview really that developed from people who use drugs for people who use drugs, and that is never going to change. It's very important that people who use drugs have input and say on everything that gets implemented in this space. But at the same time, I think it's important to note that there's different iterations of harm reduction, and implementing it in mainstream, it will always have mainstream healthcare will always have deficits compared to community models, in my opinion. There's just not the flexibility within a bureaucratized setting or an institutional setting to have that kind of rebalancing of power and other things that kind of promote the full benefits of harm reduction. And I think that's just the reality. The team has tried to counter some of those tensions by employing people with lived experience. And we are working to not only employ them, but also have them more formally involved in leadership positions in the research team for sure, and also increasingly within the hospital. So that is one way to try to fight back a bit against that tension. But the reality is it's never going to be perfect in an institutional setting. And I think that's why it's best to view harm reduction in healthcare as complementary to community practice and what's happening in community, but as never a replacement for those kinds of programs that are explicitly led by people who use drugs for people who use drugs and are really the trailblazers in this area and are the ones that are doing the coolest work in terms of innovation, in my opinion.
Hi, Elaine. So do you anticipate
Oh,
difficulty?
I lost my mouse for a second there. There I am. Okay. I have a couple of questions on YouTube. Oh,
I think
I'm
Jake was going to ask a question.
okay, go ahead, Jake, and then I'll do a couple of questions
Okay.
on
Sorry about
YouTube.
Are you expecting difficulties with regional political or administrative, how should I say, tendencies in resisting or implementing these policies? Because, for example, in Spruce Grove, there is significant pushback against masks. So, like, you can go to a superstore and see people without masks, and this is simply because the Spruce Grove City Council does not have bylaws against it. Now, I understand that healthcare is not quite as subject to bylaws, but are you seeing the potential for this kind of resistance?
Yeah, I mean, I think, in an ideal world, all hospitals would have these types of services available. But the reality is, in many settings, there isn't the same demand for this kind of care as there would be in like a big urban center. So I think it is about balancing kind of like what the community need is, and tailoring the services available at different settings to that need. There's always potential for pushback. That's why we haven't had harm reduction hospitals for so long, because it's traditionally like kind of a controversial area of practice. But the evidence is very sound that it's effective. And I have been heartened over the last few years by Alberta Health Services efforts to implement province-wide binding policy that mandates a harm reduction approach to people who use substances, and actually disallows for them to be excluded from healthcare because of substance use. So there are steps being taken in the direction to try to make practice more uniform across the province here. But that being said, it may not always be necessary or appropriate to have like this level of harm reduction services as well as additional substance use interventions available at every acute care site. Like, just as we prioritize and kind of shift resources around within the health system to meet population need in different settings, I think this is a similar circumstance. Although I would say that overall there definitely needs to be more work in all settings, small and big, to improve with the quality of care for people who use substances.
Okay, wonderful. All right, so we have a question on YouTube from Dr. Marta Urbanik, one of our faculty members, and she says, "Thank you for your talk. I recognize the significant barrier hospital security can pose for accessing inpatient services. I was curious whether, to your knowledge, security staff in the hospital have been provided training or direction with how to treat PWUD within the hospital setting, particularly since the opening of the SCS."
So the short answer is yes. There has been a lot of efforts to orient people working in the hospital, including security, around the service, including like tours, Q&As. And I will say, having worked on the site myself and observed security encounters with patients, that there are many very well-trained and excellent security staff that work at the hospital and are very professional and appropriate towards people who use substances. We've also heard data or seen data from patients that have described negative encounters. So to be honest, they're not that many relative to like unit staff. And so I think there's always more work to be done. And I think there's always that tension between how do you ensure safety of everyone at the site while still being as low barrier as possible so that people feel comfortable coming to the hospital to get help and to get care. And it's an ongoing challenge. And I don't think there is really a lot of scholarship in this area. So it's actually something I want to look at in the future, how to optimize security models for acute care settings in kind of an anti-discrimination, anti-oppression, and kind of anti-racism way.
Okay, Rebecca has a question. Go ahead, Rebecca.
Thank you so much, Dr. Hyshka. This is super engaging. To be honest, Dr. Urbanik kind of took the question I was going to go with, but I do have a backup question. So I'm not sure if in your preliminary analysis you will have been able to identify this, but you did mention that some of the unit, like medical staff, were suggesting the SCS for patients who might want to use drugs, but then there were other unit staff who were kind of punishing them by changing their medical regime or whatever it was. Have you been able to identify any differences between the staff that seem to be supportive of the SCS versus those who are not?
Yeah, that's a great question. So I want to be clear when I say that medication regimes have changed. It's not necessarily coming from a place of punishment, though it can be definitely perceived that way by patients, and I understand why. Sometimes it's coming, like staff were telling us, sometimes it's coming from they're not sure what to do, and they're worried about potentially, causing an interaction with the substances that were used at the service. And so they feel like the safest thing to do is hold medication. And so we have heard through the interviews that there is a need for more training and around like post SCS care when people return to the unit. So some more professional development, like how to assess people for risk of, overdose, which there's standardized scales like clinical tools that can be used for that quite effectively. And sometimes it's just about building up confidence and people's confidence to be able to use those tools. So I think that's part of it. And that's certainly, like, these data were collected now. Actually, we finished staff data collection just as the pandemic was starting. So there is like ongoing efforts to address these concerns and to do that further education and training. I think though too, the reality is like hospital staff reflect society, right? They like live in society. And so they bring their lived experience, their worldviews to the bedside. And it can be really difficult to challenge that in some instances. And I will say, I've been working at the site since 2014. We do hear less negative experiences for sure. And even from the community advisory group, they hear a lot less from people out in the world that, that they're being getting mistreated or whatever, but it does still happen. And I think some staff hypothesize that it's like the older or like people that have been in their careers longer who maybe hold different views towards substance use. But the reality is also that there still is no good training really for substance use in medical education. Like it is, unless you specialize in kind of addiction medicine, you're really not getting exposed to any meaningful education around substance use and how to be effective in caring for people who use substances. And so I think we need to try to change that too, so that when people come to the hospital, they already have that background knowledge and it's not something you're trying to like support people to gain while they're amidst their career.
Thank you.
I'm not sure who was first, Kevin or Sandra, and Sandra's my boss, so maybe I'll let Sandra go first.
Thank you, Jeff. Well, I mean, as you said, there are tons of parallels to prison, which is really interesting. And I have a gazillion questions for you that I will not ask right now, that we can discuss at another point. But one of the things I was wondering about is how people actually learn about the program and whether or not that has an influence on whether they use it. Like, did that come up in the evaluation where the hospital staff sort of like, educates them about it? Do people already have knowledge once they become hospitalized, or do you go around sort of like from the SCS and educate people? So that's one. And the other one related to prison is how much pushback do you get from others who might be concerned that maybe their bed neighbor in their room has access to opioids, and in what ways do you have to deal with the rhetoric that their rights are being infringed on because someone in their room has fentanyl on them, and these sorts of discussions?
Those are great questions. Okay, so there's a whole bunch of ways a patient finds out about the service. So the most obvious is if a person's admitted to hospital and the staff on the unit suspects substance use, the person's talking about their substance use, they will request a consult from the addiction medicine team. When they and as part of that consult, it discusses like, are you currently using? And there's an offer to attend the SCS. Now, it's not always taken up, and it's usually a doctor or a nurse practitioner that are doing that kind of intake consultation. For people that report that they're continuing to use, but maybe they're not totally receptive to the SCS or supplies, peer support workers will come and visit people and offer to take them on a tour, like no strings attached, of the service, just to like, if they want to see it or just get more familiar with it. People can also show up at the site without having any interaction with staff or being told to go there. And to a lesser degree, unit staff also will refer people, particularly if they see like needles or something else. They're potentially going to tell people like, did you know you can go here? There are some challenges with the way the model is implemented, and this is a tension for all of these services in hospitals, I think, is whether you kind of do it at a bedside model where you bring a staff to the person to supervise, which is very human resource intensive and doesn't allow for a lot of kind of anonymity or privacy in multi-patient rooms for sure, and probably isn't feasible to some degree in multi-patient rooms. The challenge though with the standalone fixed site is that it's hard to get to from some parts of the hospital. And so mobility can also be a challenge. And the hospital will provide a porter to assist people to get to the service if there's one available, but that's not always the case depending on how busy the hospital is. So there's those kinds of challenges. One thing that came out of our research that was really interesting and I didn't realize is there's a ton of word of mouth in the hospital. Patients meet each other outside in this kind of unofficial smoking area or in the cafeteria, and they get to chatting, and there's a lot of informal peer referral to the SCS. And a lot of people told us that they actually decided to go to the SCS after another patient told them it was a safe place to go. And so I think that's really interesting. I'd like to explore that more and how we can kind of embed more of that kind of peer-to-peer support amongst patients in the hospital and in the model. The second question was around pushback. There hasn't actually been a ton. I think if people can go to the supervised acceptance service, there's going to be actually less tension because they can take their substances, they take them to the service, they're using them in privacy, no one else is being exposed to substance use. So it's actually ideal. I think it's less ideal when there's problems with ongoing substance use in the room. That's what causes more tension. And one way that the hospital has dealt with the whole being in possession of drugs on the site, because it is a bit different than a normal supervised acceptance service, because people are going back to their beds and then they're still in possession of substances, is they've installed patient safes for people to safely lock up their substances and anything else related to drug use or their belongings. And so that's a good benefit for the whole hospital, because everybody should have a safe place to lock their belongings when they're in the hospital. And it also has helped deal with some of the challenges around patients being in possession of drugs in the rooms.
Thank
All right,
you.
Kevin. Kevin, I think you're our last question that we have time for here. So go ahead.
Thanks for that, and Elaine. Thanks. A couple of my questions have been answered, and hopefully you didn't already answer this one in your comments, and I missed it. But one of the things you said quickly was one of the fears that they have, or one of the barriers, is the prospect they fear, and I'm quoting here, retaliation from their other unit. Can you unpack what that actually means? What does retaliation on their unit mean?
Yeah, that was a quote from a staff, I think. So basically, we have to remember, historically and everywhere in major cities across North America and probably internationally, people are not treated well in the hospital when they're using drugs, right? They're identified as engaging in illegal activity. There's a lot of stigma against drug use, and so patients have had multiple negative experiences with the healthcare system before we interview them or before this current visit in which we caught them. And so those experiences set up pretty low expectations for how you're going to be treated in hospital. And so I think a lot of people, to defend against that, at least a subset of people who use drugs, won't disclose their substance use, don't want to go to the supervised acceptance services, don't trust it, because they just feel like in the past they've been treated poorly and they don't have a reason to believe that won't happen again. The main concern that people will express that they don't want their care to change, and that's specific around medications. So a lot of people are being treated with opioids for pain and withdrawal, and they're worried that their dose will be reduced if they go to the supervised acceptance service. And the way a consultation service works is the addiction medicine physician that does prescribing is not necessarily the most responsible physician. So they're not necessarily the person that's making, at the end of the day, the decisions about all the prescribing. And so the physician on the unit can actually adjust and change medications. In many cases, they don't. They defer to their expertise, and that's something that's been worked on and improved definitely over many years, not just relative to SCS. But in some limited cases, they do. And that's what patients are really concerned about, I think, is not having access to medications that are helping them to feel well enough to stay in hospital, and worrying that they'll be abruptly changed. Other people are worried that the staff will look down on them or provide them with less attentive care. And sometimes they report that happens, but often it's also just a fear that it will happen that is enough to discourage people from going to the site. So I think there's still lots of work to shift hospital culture here and certainly everywhere. But I will say, as we've been doing kind of longitudinal qualitative work in the hospital, we are seeing less of those negative encounters, but just the memory of them is enough to prompt many people not to trust the system. And we have a lot of work to do to rebuild trust between people who use drugs in the healthcare, because it's still not ideal, and that's not unique to acute care.
Right. Excellent. Thank you.
All right, so that is our time for today. So just another big thank you to Dr. Hyshka for joining us and giving the talk for this month. It was really great. And yeah, we'll be back on the 25th of February with Dr. Elke Van Helmont from Kent. And yeah, we will see you then. So I'm going to shut the recording off now. If people want to hang out, feel free to stay and chat with Dr. Hyshka for as long as you like.